We're going to transition now to our last couple of presentations, and I'd like to stay on this theme of really trying to be interactive here, because this is an issue that I'm going to bring up now. The notion of bringing new technologies into a hospital, some of the barriers, some of the other considerations. Who here sits on a new technology panel or a health technology assessment panel for their hospital? Who gets involved in discussions of bringing in a new robot, for example, or bringing in a new bone graft material? So yeah, I think a good number of people here, and indeed I think that number is going to continue to expand. And in fact, I think who wishes they had some more influence over the discussion of whether or not we can bring in a robot or bring in a new bone graft material or bring in a new surface on their implant? Who feels maybe frustrated by that conversation a little bit too? So I think if we're not participating in the conversation, then to some extent we become victimized by decisions that are made by people who have really no business at all making those decisions. I got involved pretty early on after my fellowship when the lumbar disc replacement was just coming out. And I kind of wanted to just put my head down, do my research, do my clinical work, build a busy practice. And I got involved in a discussion because I don't want to take too long in the story, but it's an interesting one. We were doing one of the first FDA trials on at this time it was a lumbar protist, and there were two protist patients who were done by my senior partner David Bradford at the time. And I did a front and back on a patient with neuromuscular, with cerebral palsy. She's actually a college student from Berkeley. And so Bradford does two lumbar discs, no charge to the hospital, and on a patient with back pain. And I'm a little bit critical of operating on a patient with back pain in the first place. And these were two work-on patients with back pain who didn't get any better. And I did an incredibly expensive front and back surgery. It was a T3 to the pelvis, and a patient with a horrific neuromuscular deformity who actually was able to get back to college. So the actual impact of what happened was dramatically different, right? Two people who ended up still with back pain and on disability compared to somebody who actually gets back to college. And I sit down next to the CFO of the hospital at the time, and I gave him the moniker Jabba the Hutt, because this guy would literally walk in, and as soon as he walked into the room, he'd take two seats, put them next to each other, he had one butt cheek on each seat. He was a disgusting human being. And to give you a little bit of insight here into where this talk is going, is I've got some really fond feelings for my patients, for my colleagues, for almost everybody. And I'm a very kind person, but I really have disdain for some of the people I deal with in these rooms. And in terms of being involved, this fellow said, hey, let's look at these two cases, and what happened in the hospital. Lost money on somebody who's a Medicaid, or in this case, Medi-Cal patient with neuromuscular scoliosis, as opposed to looking at how much money we could make on this disc replacement. And I brought up the fact that let's look at the outcomes. And he said, well, that's not my business. I look at the numbers. And then he went on to say, well, what do you think about these disc replacements? Do you think that we're paying for two end plates here? Do you think that maybe we can cut the cost by either cutting out one of the end plates, or maybe we can cut out that little core thing you put in the middle? And that's the level of stupidity that literally, those of you who are involved in these conversations, we have to be involved in this, because that's the level of understanding that we're dealing with. And so in terms of new technologies into the hospital, I think we need to be involved in these discussions. In the absence of our involvement, idiotic decisions get made. And I think we also need to be, to some extent, stewards for being financially responsible in some of these instances as well, because I think there are a lot of instances where our enthusiasm for new technologies can actually drive costs without concurrent improvement of outcomes. So these are my disclosures you've seen before. I think that they won't be relevant here because in part I'm a little bit critical of some of the innovations we've seen. So in terms of new innovations in spine surgery, we had a nice couple talks on this yesterday, but we've seen patterns of adoption, enthusiastic adoption followed by abandonment. And lots of examples there. And I think that a responsible way to think about how to bring in new technologies and how to make an argument to an HTAP committee or to an argument for bringing in new technologies would be to look at the incremental value. Look at, compared to what we're doing now, what might that incremental value be? And I'm going to show you some graphs on this, but the notion is that incremental value classically could be, I think it was Billy yesterday talked about $50,000 to $100,000 per quality adjusted life year. Well, that's one classic measure, but it may be reducing readmission rates, reducing reoperation rates. It may be improving quality of life over time. It may be reducing junctional kyphosis problems, improving fusion rates. That outcome of what we're paying for can be measured in any number of metrics. I think there are different levels of evidence that would either compel us to make a change in what we're doing now. So what would really compel me to do a minimally invasive discectomy, which is something that I've been doing over the last few years compared to doing an open discectomy? Well, I think I'm getting patients out of the hospital the same day with less pain. What would compel me to do an MIS TLIF compared to an open TLIF? Well, I don't have quite as much of a compulsion there, but maybe some of the things that Charlotte shared would support that kind of a change. Ultimately, we want to think about cost-saving innovations, and we developed a group I'll talk about briefly called the Center for Disruptive Musculoskeletal Innovation, and this was a group funded by the National Science Foundation. I'll talk about it a little bit, but the notion of disruptive innovations are innovations that actually save cost over time. Now, the perspective on how much time we want to be looking at is very different between the hospital's perspective versus the payer's perspective versus, to some extent, the physician and the patient's perspective. And then finally, I'll give a couple of examples of new technologies, and I really want to bring this open to a discussion, so it might take a little extra time, but I want to hear about other people and their experience of making an argument to the hospital for capital equipment changes, making an argument to the hospital for bringing in some innovative or new technology that might be more expensive, and we'll talk about the physician perspective and the payer perspective as well as the hospital perspective. So I think we all have lived through a period of tremendous advances in technologies, and fundamentally I think we've all got to share a lot of confidence in the promise of new technologies. Access to information is nearly instantaneous now. The notion of a flat economy and the notion of the world being flat, and instantaneously I can get a tremendous amount of information. Increased productivity, the evidence for that actually isn't as good as I would think it would be, but certainly I feel like technology has increased my productivity. Reducing errors being awfully important, saving lives, and overall just improving quality of life. And I grew up in a house that had a phone that looked something like this. So I had 3 brothers and sisters, my parents, so 6 people in the house. We had one rotary dial phone, and now everybody in my house, 6 people in my house, but everybody has a phone that looks something like this. And there's almost nothing that I can say that's more interesting to my kids than some Angry Birds game or some chat that they've got going on that phone. The capacity of that phone is terrific, and we talk about the storage capacity of computers and phones. The new iPhone's got a capacity that's some 1,000 times more than the computer system that sent the first space rocket to the moon. And a lot of this had to do with William Shackler and a group. This is in Belmead, New Jersey. These guys were developing some of the very first transistors. They won the Nobel Prize in Physics, and this was in my backyard where I grew up in New Jersey. And of course, many of you know Gordon Moore, who went on to quantify this. And Gordon Moore was the founder of Intel, and one of the people who really developed the ability to increase transistor capacity per die using silicon and germanium and other elements. And Gordon Moore back in '65 noticed that, hey, we're doubling every couple of years, doubling the capacity of a transistor to actually store information, and that's continued all the way through present times. In fact, there was an article, might be the next slide. Now, there was an article in the New York Times just last year of Gordon's, maybe it was a couple years ago, but Moore's Law has turned 50 and is the end in sight. But the point being that terrific advancements in technology and storage capacity for computers and technology over the course of our lifetimes. Well, what would happen if that would be applied to medicine? What would happen if every 2 years, instead of a doubling, we had a halving of infant mortality rates of implant failure, of readmissions, reoperations, complications? What would happen if that kind of quality improvement we're seeing in medicine? And I think there's some hope for that. At the same time, there's some skepticism, and this is many of you are familiar with Scott's parabola, so the notion that you have a promising idea and early on some enthusiasm, some strong media reports, then it even becomes a standard treatment, and then suddenly there's a couple damaging surveys, some follow-ups, some condemnation by authorities or reimbursement people, followed evolves into disuse and ends up with very old surgeons amazing their juniors with rollicking stories of the old days. And I think we can all think about examples of that parabola that occurred with everything from different types of osteobiologics. I'm not sure the lumbar disc replacement, I'm not that critical of it, but maybe that's also had a bit of a peak and drop. Certainly dynamic stabilization devices, maybe some of the interspinous devices have really followed that kind of pathway. At the same time, I think there's room for some optimism in what's really happened with technology in healthcare. Well, one of the things that's really dramatically changed is our ability to genotype. And where it used to cost a terrific amount of money per base pair to try and genotype, that's now dropped even more than the rate of drop of cost for computers. We're living at a time that's really exciting right now. I think to some extent, Scott Topol talks about this great inflection point where now we've got this convergence of old medical knowledge, but we've got new computing power, we've got the internet and social networking, we've got all sorts of sensors, and in the Silicon Valley, I'm working with all kinds of people who want to put my patients in all these types of suits to measure their heart rate, measure their pulse and respiration, and measure sweat, and looking at genomics, looking at imaging information. We got the opportunity to really have a terrific inflection and maybe some further improvements of how we're providing care. At the same time, it doesn't come without expense. And if we look at the first decade of the century, looking at the cost of care, 3.6 million fusion-based procedures, almost $80,000 of direct cost per case now, so $300 billion of expenses. Within the Medicare population, the thing that's increasing most of all is the rates of complex spine surgery. In fact, we wrote a paper recently suggesting that in patients over age 75, the rate of multi-level fusions has actually been the sector that's increased most out of everything in spine surgery. And there's a big cost burden associated with this, and that cost burden is now approaching and in some cases exceeding many common medical conditions, diabetes, cardiovascular disease. Michael Legrone talked about the fact that it's worth it. These people have the disability that exceeds cardiovascular disease, that exceeds diabetes. At the same time, you see why there's a geometric rate of rise, and this is a paper that was done some time ago by Rick Delamarter and Hyun Bae and some others down in Los Angeles. But what they looked at is the average cost per surgery was increasing linearly, but then the actual amount of surgeries were increasing linearly. So you've got an increase in the cost per surgery and the increase in amount of surgery, both linear, then that becomes the geometric rate of rise. And that's where we get costs of healthcare that are rising geometrically. And there's not a clear evidence to suggest that by spending more, we're getting better outcomes. In fact, there's some evidence to the contrary. There's evidence to suggest that patients who are in higher spending regions, and many of you know the comparison between El Paso and what's the other town in Texas? I cut this slide out. Who's our Texas people? The comparison that Atul Gawande did with El Paso, Texas to another border town in Texas. And there were dramatic differences in the cost per Medicare patient. It's almost a threefold difference. Well, it turns out that patients in higher spending regions are actually less likely to get evidence-based treatments, and they're no more likely to get elective surgical procedures or preference-sensitive care. And for many serious conditions, things like heart attacks and stroke, actually patients in higher spending regions actually did worse. To some extent, excessive treatment results in worse outcomes. And one of my better examples, I'm not sure if it'll be true this year again, but is the Dodgers having the highest salary in Major League Baseball and still not winning the World Series. We'll see how long that lasts, but it's been good so far. So what are the drivers of healthcare in the U.S.? Well, Paul Ginsberg was an economist at Princeton, and he suggested that the development of new technologies that add costs without a clear improvement of outcome or a clear improvement of performance is a major driver. And to some extent, he suggested that in the U.S. particularly, we're enthusiastic adopters of new technologies, of pharmaceuticals, of off-label pharmaceuticals, of non-formulary pharmaceuticals, of new surgical techniques, of new medical devices, and we adopt these without a lot of evidence to suggest that these are going to really result in a benefit. And again, some of the examples that we've talked about, the lumbar disc replacement, dynamic stabilization, interspinous devices, to some extent vertebral augmentation, certainly for osteoporotic fractures. So what is the value of a new technology, of an innovative approach? And I think there's a difference in the perspective. And this is what I want to get at a bit, is the perspective of the payer. Well, for a payer, in general, and I was going to ask Scott about this, but there's evidence to suggest that most commercial payers, most people get off their payroll, within 2 years. So, for example, if you're 62, 63 years old and on United Health probably doesn't care a whole lot what happens 5 years from now, because there's a really, really good chance that you're going to be on Medicare by that time. And most people, between job transitions, they transition their health care within a couple of years. So a payer might not have a whole lot of incentive to know what's happening 5 to 10 years down the road. They definitely want to reduce their costs while you're under their coverage for on average 2 years. The hospital perspective may be even shorter, 30 to 90 days, right? What happens if somebody gets readmitted as a reoperation within that short period of time? Well, that can be really problematic for the hospital in terms of quality metrics, in terms of their contracts, and now with risk sharing and bundle payments, that's a direct risk that hospitals are taking. But having said that, what happens 6 months down the line after that bundle's done? Well, that becomes a new source of revenue all of a sudden. Sort of like BMW making a transmission that reliably fails at 110,000 miles. If it reliably fails at that point, that's a real bonus. The trouble is having it fail before 110,000 miles and then being called unreliable. Policymakers certainly have different perspectives, the industries that we work with, and I put the patients and the providers together. What I mean by the patients, and in this case, us as the community of physicians who take care of patients with spinal disorders, I feel like to some extent we're the ones who are really committed. You think about breakfast, right? The chicken makes a contribution to your breakfast. The pig makes a commitment to the breakfast. And to some extent, I think the patients and the surgeons are the ones that are really committed to this, and they're the ones that are really thinking about the long term. When I operated on a 14-year-old adolescent with idiopathic scoliosis, I'm not thinking about 30 days, I'm not thinking about 90 days, I'm thinking about what happens when she's 50 years old, 60 years old. One of the most common things I talk about is what happens when you're your parents' age. And I think that's a very different perspective in terms of a level of responsibility as well as an accountability for the long-term results. So when we think about the physician perspective, we're first thinking about certainly patient safety, right? Going back to the Hippocratic Oath. We're thinking about how do we change health status, so some of the metrics for health status, making sure our patients are satisfying, limiting complications, and that's part of safety. And cost, quite honestly, doesn't necessarily come into my thinking a whole lot. I'm willing to spend a whole lot of money to avoid a complication. I'm willing to spend a whole lot of money to get a better outcome if that were the end result. So cost is probably lowest on my perspective, whereas for the hospital, that suddenly becomes predominant, right? In the hospital language, rather than looking at change in health status, the hospital looks at a contribution margin, right? What's the change in our revenue compared to our direct costs? Quality metrics, 30, 90-day readmissions, and oftentimes if we're trying to minimize that, we're not necessarily undertaking the type of an intervention that may be appropriate. Complications, of course, are appropriate. I think long-term outcomes, probably aren't quite as important. I think those are lower down on the priority list. One of the things from the hospital perspective is the notion of limiting vendor policies, and we've heard about this, having 1 or 2 vendors per hospital, and from a physician perspective, we certainly want to have access to the best of all new technologies. How many people are working now in a hospital that's got limited vendors? They're limited to two or three vendors, and how many people can bring in any new thing at all? I see that new cervical screw system. I really like that. I could bring it in within the next week. Who's in that kind of environment? Fewer and fewer, but sometimes it's nice to have. And I'm not sure how effective limiting vendor policies have really been. We'll talk more about that. I think with alternative payer models, again, this really involves sharing risk. So transitioning from really a fee-for-service system into an accountable model where suddenly the payer is kind of offloading risk to the hospital and to some extent to the surgery with regard to reimbursement. And I think this really changes quite dramatically how we think about bringing patients to surgery. I'll just give you an example here. We look at some of the spine bundles, and I know the NYU group's done a lot of work with this, and at UCSF, I've also been quite involved in this at UCSF. So you look at the 4 bundles for spine. They include anterior, posterior lumbar surgery. They include posterior lumbar surgery, cervical fusions, and then non-fusion procedures. And if you take a look at this, so 453, 454, 455 are all anterior, posterior procedures. and depending on whether there's a major comorbidity or complication versus no comorbidity or complication, these are the average Medicare spends per patient. So if you're going to get reimbursed, let's say $54,000 for a front and back surgery, then suddenly you're in a situation where you're taking a lot of risk for loss. One of the things I'll point out on this graph is a lot of the cost actually comes from the post-acute care. So what happens after the patient's left the hospital? So to that end, one of the things that's changed dramatically in our practice is we're making sure patients do have a place to go after they leave the hospital. When somebody gets transferred to our hospital, which is some of the longest lengths of stays, that's such that we make a contract with that transferring facility that we can send that patient back to the facility afterwards. We make sure that patients have somebody at home who can take care of them after surgery. That's a big part of our systems reform in preoperative preparation, because those costs in a bundle will absolutely ruin any possibility for profitability. So I just thought a couple of examples that we'll talk about here. Capital equipment. Somebody said, I think Jim Swender said he likes to use the Axis table in Minnesota. Who's got an Axis table in their hospital? We've got a couple of these, but most of our tables aren't Axis tables. And if you wanted to bring an Axis table into the hospital, I think, help me out on this. I think we recently $24,000.
Oh, no. Well, we've got a great deal in California. Ours is about 116,000.
All right, maybe I'm way off on that then. All right, so the point being, how's that discussion happen then when you want to bring in a new one? How's that discussion happen in your hospitals? Is that a barrier to anybody? Is that a problem? Do people have? I can tell you this is an active issue. We've got a capital budget every year. This is an active issue at UCSF. So we want 2 more of these tables. We want a new. We've got a couple of our neurosurgeons want to have a new intraoperative CT. So we've got 4 O-arms in our hospital, and on any given day, we're typically running 6 or more spine surgery rooms. So there's 4 O-arms in there, and a couple of guys want to get one of the intraoperative CTs that's attached to a bed. There's a whole bunch of different ones, not to get too proprietary about it. But you want to bring in a new CT scan. Is that an issue for anybody in your hospital? Or Jeff at Hoag today, Jeff asked for it, so we'll get it next week.
Well, it's interesting because when you start owning the hospital, that discussion becomes a little bit more reality, right? So I think you have to balance things. The problem is how quick does this technology change? A table tends to last 5-10 years, maybe, and certainly you can probably justify amortizing that over that length of time. The Maser robot or the new robots, that technology may change where it's obsolete within a year or 2 and gets put in the corner and collects dust. And so you have to be, somewhat, we tend to kind of pool the surgeons as a whole and figure out, is this something the majority of the surgeons want? But there's a capital budget ahead of time that, we have to look at. The other things you look at, can you charge for it? Is it purely a cost, or is it a profit, or generative something?
So that's the next perspective I actually want to bring in, and you brought that forward. Is it, when you own your ASC, when you own your hospital, does that change your perspective in terms of whether you're willing to invest in new technologies or new equipment, and how does that change your perspective? I think to some extent, when we think about bringing in innovative or new technologies, what we want to see is something that actually adds value, improves outcomes, or to some extent that might actually save some costs. And this gets to the notion of the geometric rate of rise of healthcare costs. And one of the attempts that you're all familiar with that was made to try and reduce healthcare rise was the sustainable growth formula. So that was something that was actually eliminated under Obama now a few years ago. But the sustainable growth formula was the notion that we would drop 5% off the total cost of healthcare by just essentially reducing payments by 5%. And every year, as you know, that got voted on by Congress, and it was put off for another year. But it's really not a great solution, because all that does is shift that curve to the right? It doesn't actually have any impact on actually reducing the slope of that curve. But if we were able to identify some new technology that actually could change the slope of the curve, so something where we might make an investment on the front end such that we'd save costs on the back end, so something that might reduce the rate of revision surgeries, something that was more expensive but would improve our fusion rate. more expensive but eliminate complications for junctional kyphosis, then that makes sense economically. That could be an investment that's worth time, that's worth while. So if we can spend more money on the front end to reduce our infections, well, probably within 30 or 90 days, that would be a dramatic improvement, and the hospital would see that perspective, and we'd see that perspective. Something that might improve fusion rates, and it would be an outcome that we would see at 2 years down the road. Well, the patients and the physician would certainly appreciate that. I'm not entirely sure that the hospital or the payer would necessarily appreciate that type of increase in short-term costs. So again, when we think about cost effectiveness of new technologies, this notion of what are you willing to spend for an incremental gain? And to some extent, if something's more expensive and less effective, well, we'll reject that all day long. Something that's less expensive and more effective, well, we'll adopt that all day long, but in general, that's not how our industry partners tend to price things. So usually we're operating on what I call the line of clinical equipoise, and this is from an article that we put into Spineline some time ago, where we're willing to spend a little bit more for some measurable incremental value. And what might that incremental gain be? Well, it may be an improvement of survival, a hip implant, a knee implant, a spine implant, maybe a reduction in revision surgery, maybe a more reliable change in health status. If I could reliably get a better improvement of ODI scores, a better improvement of EQ5D, it's pretty rare that innovations show that, but maybe some of the cervical disc for 2-level, we saw some evidence for that. And oftentimes, though, we're operating on what I call the area of clinical equipoise, where there's not clear evidence to suggest that a change is going to make a difference. And I think the degenerative spondylolisthesis example might be one of the better examples here, is the notion of how do we approach this? And I think Jim did a nice job of talking about this. And to some extent, this case is probably would generate more controversy than some of the major deformity cases, because there's so many different things we could do, right? We could decompress alone. We could decompress and just do a posterior fusion. We do some kind of dynamic stabilization. We could do a posterior-based interbody fusion, and we could do a front and back surgery. And there's a dramatic difference in the costs of those interventions. But having said that, the reimbursement might not be that much different. So as Charlotte suggested, the hospital perspective is terrific for degenerative spondy to do a minimally invasive decompression and send a patient home the same day. Doing a front and back surgery, especially a staged front and back surgery, which we've seen in some practices, can be incredibly expensive for the hospital, and suddenly the reimbursement might not justify that. So it's going to give you some financial transparency here. I don't know projecting, but doing a front and back surgery, the contribution margin at UCSF for front and back surgery for a degenerative spondy was about still $27,000 positive, but to just do a posterolateral fusion, the contribution margin was almost $60,000. So that's a pretty dramatic difference from the hospital perspective. And as anybody did a TLIF on that, which wasn't the most cost-effective solution there. So is anybody right now feeling that they're getting any pressure from either a hospital or a payer towards influencing their approach to common situations?
So I would tell you not on a case-by-case basis, but in a very primitive manner, there's not hospital systems or more insurance, local HMOs say, are looking at the average cost per surgeon for a fusion and then directing patients accordingly. And the problem I argue there is you're not looking into posterior, or deformity for that matter, and so they're very primitively looking at the cost per case, though, and starting to direct patient care.
Yeah, I'm just going to point out, I want to hear other comments here, but I just got a note from our new CSO, Jabba the Hutt died of a heart attack, and nobody went to his funeral, but we got a new CFO, and brought Chris Ames and another guy and I into the office, or asked us to talk, and basically brought up the point that we're significantly more expensive per case. And I asked, well, are you talking about for a lumbar discectomy or for a T3-S1 fusion? Well, I don't know what you're doing. All I know is that your cost per case is this much more expensive, right? And there's no insight into the risk stratification, into the type of cases, or even into, in this case, what the reimbursement was. If you said that your contribution is less per case, contribution margin is less per case, then there might be something to talk about. But please. What do you think the basis for that is? What genius suggested that allograft is worse at 3 levels versus some synthetic?
We probably got a third party who's done some biased literature review that's looked at a paper that says the diffusion rate's adequate with that, so that's all the paper. But a lot of the
Suggesting a synthetic would do better in a multi-level fusion.
I didn't talk about how skewed the database about effectiveness of diffusion rates and that sort of thing for surgical
Yeah, Jim?
Same with Minnesota. It's not the hospitals that are limiting what we do, it's the payers. For instance, several of the payers do not allow us to use cannulated payers for any reason, because they call it infused experimental, even if using it on the FDA-approved, IV study that was done. So the payers are doing that routinely with us at this point. Even, for instance, artificial discs are artificial discs. As we know, there's 2 on the market right now, with non-cutting that's approved for 2 levels. FDA approved for 2 levels. They will only allow us to do it at 1 level. So, OVC and Prestige can only do in Minnesota with health partners and across Blue Shield 1 level.
I think the more egregious thing is that the pharmacies at Walmart will fill no prescription for an opioid more than, I think, 21 pills.
Opioid naive
Yeah,
patients.
21 pills.
Yeah.
That's
They'll
good.
stop their spine fusion, no matter the severity of the spine fusion. 21 pills.
Yeah.
I've had to go, there's something called Good RX, which is basically a discounted fee cash for prescriptions. I had to go as far as print out a whole sheet with that on there, and I tell patients every time I write a narcotic, I will not get pre-authorization for more than 7 pills. 90 pills, Vicodin is $20. Make sure if the pharmacist says you won't fill it. So now in California, or maybe across the country, the pharmacist can deny the number of pills just based on what he feels comfortable giving out. So it's not just the insurance.
It's just the egregious
He or she.
practice of medicine without a license. That's
So I had a Scully, idiopathic 14-year-old, 40 Vicodin post-op, they gave him 7 on a weekend. And then I'm getting calls all over. Right. But United Healthcare and Aetna sends you a sheet for every surgery, which you have to describe every company, what model, what allograft, and they ask for crazy things, like are you doing a metrics decompression versus an open decompression versus, it's like. And I'm interested to know, I don't think they have the follow-through to actually find out what you did, right? I honestly, to be honest, because I don't even know the models of the screws we're putting in. It's in my schedule, I don't even know what it's called. Call the rep or something, but it's gotten very controlled.
Yeah, so I think fundamentally right now, as everybody's recognized, the payer is influencing the practice of medicine, and I think more and more as hospitals get more sophisticated, that's going to be happening as well. So just a couple of examples where I think there's some evidence for cost-saving innovations. And we had a nice talk earlier about robotics, and this was a paper I thought was interesting. This was John Steele put this together, looking at the cost-effectiveness of navigation in this instance, that suggested if we look at reoperations, the reoperation rate in patients who underwent navigated surgery was less than 1% compared to patients with multi-level fusions who had reoperations with non-navigated surgeries. It was 6%. If you take $16,000 per reoperation, then that actually became cost-effective at about 250 cases per year. So certainly for a hospital, that would be very cost-effective. I think in terms of robotics and computer assistance, it's somewhat variable. Doing a case like this is a young girl with a congenital scoliosis that I took care of, did a 2-level VCR, and I'll typically actually make a 3D printed model. I'll use navigation. I don't use a robot for this at all, but to do a 2-level VCR, I think I could do that better navigating these screws and get better control of the spine than trying to do this freehand. Having said that, my experience with the robot is a little more limited. This is the kind of case that I try with a robot. I actually don't try really big, complicated case with a robot because it just takes too long already. But this is where I'm sort of experimenting with some early experience with the robot and getting very precise pedicle screw placement. But in my hands right now, I'm not really doing complex things with the robot because it already takes a long time to do a complex thing, and I tend to do pretty simple things just to get to know the robot. A couple more items for discussion. I just think I'm keeping a bit of an eye out on the time here, but I think we're gonna end at 7 with just 2 more talks. Implant materials, some novel surfaces. All of you have seen over the course of this weekend the new HA Peak, and we've had a couple talks on that. I think that's an innovative surface that I've been pretty enthusiastic about. Porous Peak, some people are using 3D printed titanium. Compared to allograft in general, these are all more expensive. Does anybody know how much more you get paid to put in a prosthetic interbody device compared to allograft? Yeah. Yeah, so it's pretty variable. I know. When I last looked at this a few years ago now, but compared to doing ALIF with a structural allograft, which is how Jeff and I all learned how to do it, if I put in a prosthetic interbody for an ALIF, I get paid $1,200 more just for the convenience of not cutting a femoral ring, which is kind of a perverse incentive. Now, having said that, when you look at some of these interbody devices, and we had some discussion about this earlier, but the notion, I think some of these novel surfaces certainly are better than Peak. I'm not sure they're reliably better than allograft, but having said that, compared to smooth Peak, I think the HA Peak composite, I think that some of the titanium devices are more more reliable than smooth Peak, certainly. So I've got a lot of enthusiasm for these novel surface technologies. Having said that, who's got any idea how much difference you're paying in price for an ALIF, say for an acid-etched titanium ALIF, so a Titan ALIF compared to the Peak? Anybody know what the difference in price is? Because it's quite variable for your hospitals and for different group purchasing organizations. For some people, it might not be different at all, but who's paying a premium for a novel surface? Is anybody familiar with this? And this is what I mean by being stewards. Is we did a survey in the SRS, and the vast majority of us are completely ignorant of what we pay for anything anyway. But so you're paying more, right? I can tell you that at UCSF, Titan had asked for $7,200 for a acid-etched titanium plate, and as you know, they're working with T-code to try and show some difference there. And compared to some other novel surfaces, these get, I think, have some surgeon advocacy. And to some extent, we've got every one of these devices available at UCSF, but we actually brought them in rather than saying we'd only have 1 or 2 vendors. We brought them in with the understanding that you'd come down to the price to within 10% of the price of the alternative. So we did suggest that we were willing to spend some premium for novel surfaces. So I think right now an ALIF is somewhere in the range of $2,400. So somebody comes in and says, so any of these can come in for $2,400, or to be within 10% of $2,400. But when somebody tries to come in at $7,200, suddenly that becomes pretty untenable. So how have you dealt with that in your hospital?
And now there's more discussion about, is there really benefit paying that much more if you're offering bigger changes?
Yeah, so what level of evidence would we want to see? Do you want to see less subsidence? Do you want to see better fusion rates? Do you want to see less reoperations? And we really don't have that kind of comparative data. So right now, bringing in new technologies is something that I think is best done with us as stewards by trying to recognize, yes, there's some incremental value, but at the same time, trying to keep the prices reasonable. I tell you what we did at UCSF with the Titan cages is it was pretty outrageous, and for a number of reasons, they weren't willing to budge on the price. So what we said is that we would use the Titan cages without BMP. So you can use them at UCSF, but you can't have BMP. can't use Titan cage with BMP. And that was one way to try and, where the hospital actually manipulated surgeon behavior. Does that sound outrageous to anybody, or is that something that people are seeing? What's that? Yeah, okay. So yeah, these are the kind of...
Some of these hospitals in this cost-plus model, I don't know how many people are familiar with that, they're happy to pay that much because they're charging so much more on top of the implant.
I think there's gonna be a balance in medicine where they're looking at the cost of surgery, cost of care, the episode of care, right? So as we talked about, it's a zero-sum game. So as surgeons, we're gonna have to decide, and I've tried to balance both sides of this field, but do you support the more expensive cage while at the end of the day, the insurance company may start knocking down your fee? Or do you push the instrumentation company to say, listen, I know it's new technology, but everyone's got 3D printed, titanium now, everyone's got some surface, and you need to meet the price. If you want me to use it, you need to meet that price. I mean, listen, I think, the day that you just pound your fist and say, you may be doing yourself a disservice, to be quite honest with you, because, I can tell you, as soon as you own the hospital, as soon as you start getting into risk sharing or bundled payment, you're gonna quickly change your attitude of, hey, you need to get in line. And when you think about it, 3,000, 5,000, I don't know, whatever the price is for the nailless cage, is probably not outrageous. Compared to where you look at surgeons' reimbursement compared to implant reimbursement, I think the decline in surgeon reimbursement, especially throwing out codes and the more work we have to do, has declined significantly. So I would tell you, Scott had a very important point, running a big group and owning a hospital. It's better to get involved in these committees and kind of be able to steer the discussion to get what you want, because they're not going to budge as they're consolidating hospitals. This is the first time Providence bought a St. Joe's, Orange County, 15 hospital chain, and they told us, these are the companies you're going to have. We're able to manipulate one or two, but this is what you're going to have, take it or leave it. I don't care how much money you make for our hospital. This is it. And that's the first time in 20 years I was told that as a surgeon.
When we did our hospital, we just set a capitated program, so it doesn't matter if the Cadillac implants in there or you just do generic screws or rods and get them seen, and then you might get them seen, so.
Yeah. Well, that's what we've got at UCSF, and the purpose there was try and optimize surgeon choice, but at the same time, for a lot of hospital systems, there's a lot of overhead to the hospital for managing all those the different implants, and more there's pressure to move towards limited vendors, and the choice of which vendors those are oftentimes doesn't make a whole lot of sense either. So I'm going to wrap up now, because our next talk's going to be on osteobiologics, and I'm going to really introduce that talk with the final example of, demineralized bone matrices, I think, are a classic example. At UCSF, we surveyed, this was in 2015, we used a total of 22 different vendors for demineralized bone matrices. And the difference in price for 10 cc's of DBM was anywhere from $1,200 for 10 cc's up to, at one point it was $5,200 for 10 cc's of a cell-containing DBM. I guess that's my signal. I'm getting pulled off here. Is that right? Okay. And so looking at DBMs in general, who's using cell-containing DBMs now? Routinely, DBMs with cells, and who's using DBMs without cells? So. Who's using DBMs at all in any of their work? So most people. So to that end, the idea of getting a premium for a cell-containing DBM, when that was first brought to us by a couple of different vendors who, between Osteocell and Trinity and a couple of different vendors, I suggested, that's a terrific idea, love it, love to make it a new category. So on our implant formulary, we'll make a new category of a cell-containing DBM, and we'll put it in a different category, but I need a little evidence to suggest that there's some benefit to it. And wasn't much evidence generated, so we went out and actually did a study with Jeff Lotz and a couple of others, comparing cell-containing DBMs to non-cell-containing DBMs, and in an athymic rat model and a submuscular model, we weren't actually able to show a difference So to that end, we still have surgeons who want cell-containing DBM, so we are paying a premium. It's not a perfect system, but at the same time, I think that those are the sort of levels of evidence that we ought to really be holding accountability for, to bring in a technology that is more expensive. So with maybe osteobiologics being the ultimate example of variability in what we do in our practices and in costs, I'm going to now introduce our next speaker, and we're going to have Fred Moe come up and give us an evidence-based approach to osteobiologics. So with that as a setup, Fred,
Thank you.
we'll have you talk about osteobiologics.